In this audio lecture, we're going to be reviewing the functions of potassium and then discussing the first disorder associated with potassium. That's going to be hyperkalemia. So potassium is going to be the second most abundant cation in the body. Now, it is the primary intracellular cation, whereas sodium is the primary extracellular cation. And so we really see this concentration range between 3.5 and 5 milliequivalents per liter. And if you remember all the way back to anatomy and physiology, you'll find that we absorb potassium in the various locations in the nephrons. This is the part of the kidney, and so the first region we see is the proximal convoluted tubule. Next is the ascending limb of the loop of Henle, and then the distal convoluted tubule are all going to be sites of potassium reabsorption and secretion. And then we find that in the gut we also absorb a lot of this potassium as well. So really the kidneys are really going to be a large loss for kidneys or for potassium, and is due to the aldosterone function, and then also acid-base balance, in that we exchange it for hydrogen moving in between cells. And so in acidosis we're going to expect hyperkalemia to be a product, and then for alkalosis we're going to expect hypokalemia to be products. So for the hyperkalemia specifically, this is going to be concentrations greater than 5 milliequivalents per liter, and really we see this hyperkalemia due to decreased elimination, meaning we're holding on to it. So this could be due to renal failure. Remember that renal failure, we start to see a reduction in glomerular filtration, and anytime you see a reduction in glomerular filtration, it means that we're not removing waste products, and potassium in this case is a waste product, and that we have plenty of it generally. Okay. Addison's disease. Now, if we have decreased aldosterone levels, which is Addison's disease, now we have reduced elimination of potassium exchanged for sodium. Now, certain medications could also cause this, and so we could look at potassium-sparing diuretics that are going to act on the distal convoluted tubule. So diuretics that promote water loss without the accompanying potassium loss. And we could see that angiotensin-converting enzyme inhibitors also reduce the elimination of potassium, not due to any action of aldosterone on the kidney, but more to angiotensin II's effects on the adrenal cortex, and that it reduces aldosterone so angiotensin II generally increases aldosterone secretion. But in this case, if we block the formation of angiotensin II, now we decrease the production of aldosterone, and then we lose the capacity to secrete some of that potassium. Now we could also have another condition involving aldosterone. Aldosterone is heavily involved in potassium elimination, and this is called Gordon syndrome. So Gordon syndrome means that the kidneys are non-responsive to aldosterone, and so now the hormone's being secreted, but our body's just not responding to it. So we could have an increased compartmental shift, meaning that we are moving potassium. Remember that potassium is highly concentrated inside of the cell, and so if we run into an acid-base disorder like acidosis, now one of the buffering systems is going to be this potassium hydrogen exchanger, and so moving it between the ECF the ICF and the ECF. This is going to reduce the pH, or it's going to increase the pH, but at the same time it's also going to be increasing potassium concentrations. Now, the third cause of hyperkalemia is excessive intake. Okay. So this excessive intake can include oral supplements, salt supplements, either salt replacement for meals and processed foods, or rapid intravenous infusion that we'll talk about again in hypokalemia that is important to take care when you're doing this. So the following manifestations can be attributed to hyperkalemia: muscle weakness and paresthesia, uh, flaccid paralysis, and really all these weaknesses and paresthesias can really be attributed to this buildup of positive cations inside of the cell. So if we think back to a cell, it has a high concentration of potassium, and if we have a high concentration of potassium in the ECF, now really our concentration gradient is minimized for this potassium, and so we get more potassium remaining in the cell. Okay. Now you would think that these manifestations don't fit in. Well, they do fit in because we can actually get neuronal dysfunction due to this membrane slight depolarization. So now we're bringing the resting membrane potential up closer to threshold, and if we bring the resting membrane potential closer to threshold, we are making it easier to stimulate. Okay. Why would this result in muscle weakness, you say? Well, this is because now, since the neuron is firing at a higher rate, now it is actually going to downregulate our sodium channels. And remember that sodium channels are responsible for depolarization primarily. And so if we increase the number or decrease the number of sodium channels, now we can actually generate this muscle weakness because we have a new resting membrane potential now, and our body is adjusting to this new resting membrane potential. This can result in muscles that are more difficult to stimulate. We have to release more sodium, more acetylcholine to generate the muscle's contraction. So we get muscle paralysis and also the paresthesia. So paresthesia is tingling or numbness. And so the tingling or numbness can result because now we have neuronal dysfunction. One of the primary manifestations of hyperkalemia is ECG abnormalities. And so specifically we're looking at a dysrhythmia, and we're looking at a tachycardia really resulting. So really we could change this in a number of ways. We could either make it more difficult, we could increase the rate of firing, or decrease the rate of firing. And so we can see that if we look down in this figure down here on the ECG of a hyperkalemic patient, we have a low P wave, which means that our atria are not polarizing as well, and then we also see an elongation of the interval, and this is going to be due to the reduction in sodium channels that result in this depolarization. Okay, that result in the automatic the unstable resting membrane potential. Next up, so if we get so much dysfunction here, now we could get into cardiac arrest where we can't stimulate our muscles. For respiratory system, we're going to expect respiratory depression because now these cells don't fire as well because of the reduction in sodium channels. So a condition that we would expect there to be increased muscle activity, we actually expect there to be reduced muscle activity due to the decrease in sodium channels. And non-specific manifestations are going to include nausea and diarrhea, and that's going to be due to the neural dysfunction, but are relatively non-specific and don't really help you diagnose this too much. Okay. So looking at the diagnosis, we're going to complete a patient history and physical examination, looking for any of the manifestations that we've seen. And now if we run a blood chemistry, now we're going to expect levels of potassium above 5, okay, and then our electrocardiogram is going to show really this prolonged P to R interval, and then we would see some arterial blood gas changes, and we might expect to see a higher than normal partial pressure of carbon dioxide because now we might have an acidotic condition encouraging this development of this disorder. All right, so treating hyperkalemia, we're going to try to minimize dysrhythmias by administering calcium. So if you remember back to anatomy and physiology, calcium was heavily involved in cardiac contraction. We get opening of calcium voltage-gated calcium channels when we reach that threshold for depolarization of our funny current channels. Um, we'll want to treat the acidosis if that's the causative factor, so by delivering sodium bicarbonate, and so the sodium bicarbonate is not only going to buffer the hydrogen, the free hydrogens in circulation, but also reduce the pH of our body so that the potassium is now going into the cell instead of out of the cell. Okay. The third mechanism is to reduce the extracellular fluid potassium concentration by reducing the intake. Okay. That is going to probably be our primary method, but if that doesn't work, we'll try dialysis, where we'll want to clean the blood, increase gastrointestinal losses, maybe through a laxative, intravenous fluids, trying to dilute the ECF, and then potassium diuretic. So unlike hypokalemia, where we're going to use a potassium sparing diuretic, we're going to try to increase the elimination. Now, insulin administration is really going to pertain to diabetics. So we're going to see that insulin secretion is dependent on potassium channel, and so when this potassium channel closes, now insulin is going to be increased, and so we can increase glucose uptake by cells and also decrease extracellular potassium in the same efforts. So that is the end of our hyperkalemia lecture.